part of the thing I want you to think about is just from a systems perspective through your organization is, what are the challenges in your organization? Um, I'm going to say a weird thing. I'm going to say that we were lucky that we had 40 injuries in a month. And we weren't lucky. That's not luck. But what happened is it opened eyes and it opened leadership eyes to a problem that had been there that was just waiting to explode in a sense that did explode. And so that kind of brings people to the table to say we need to do something differently. And in that meeting that we had initially, where people are just trying hard to solve a problem, good intention, but probably not the right strategy. They asked me if I'd consult on those kids, and I said no. And I did consult on the kids, but I said no because what I said is you don't need a consultant, you need a systems intervention. And I think that's the thing I want people here to understand is like, do you just need a person who's going to help provide some expert information, or is your system part of the challenge? And so what I knew in listening to people talk is that we had a whole systems issue. And so so basically I just leveraged, I'll help if we can build a system, and we got a yes. And then we developed a committee and we started work and built an entire service that has just grown exponentially because it's been so necessary and needed. And so again, we started small. I was the initial program, and now we have 24/7 staff. But anyway, if you know these challenges in your organization that are happening, that are, I'm going to say caused, but they're, it's not, the children aren't your problem. The individuals with autism, people with autism are not your problem. It's just our system struggles to manage these situations. So if you have an area that you want to kind of use to focus interventions and guide, are you making good progress? That's helpful. We've definitely, we work with our family relations department very intimately, where initially there were a lot of parent complaints and we had a lot of staff complaints. It was not easy to work with this population because we didn't have the infrastructure to support it. And all of these things existed. So, but you can't track them all. But anyway, if you have a few of these to track, it really helps you kind of gauge what you're doing. And so a lot of systems actually don't know how many staff injuries they have. They don't know how severe they are. They don't have great systems, although I'd say most places are coming, but I work with the Solutions for Patient Safety group, and we have a pioneer cohort working on behavior safety in hospitals, and we still have, we have about 40 hospitals in that group, and many of them still struggle to track injuries. So it's hard. We were lucky enough to have that pretty well built in our system, although we did improve it. So I want to give an example. Quality improvement, I don't know how many of your hospitals use quality improvement methodology, but it has been instrumental in how we have approached improving care for individuals with autism and other developmental disabilities or any behavioral health risk. And so this is just a quick example, but in our emergency room, there were some root cause analysis work done on some major events that looked at a bigger systems level, and then they kept breaking portions of this down and doing small quality improvement projects to improve our overall emergency room process around anybody with behavioral risk. And a lot of these patients had autism. So it wasn't exclusive, but many of them did. And they worked hard. What they found is that the use of like a PRN medication for agitation was all over the place. What they were using, how much they were using, when they used it, et cetera. And a lot of this work was done around injury. I didn't put the injury graph up. But there was quite a few staff injuries, and so they were trying to kind of do this whole, how do we manage agitation? And there was another side that worked on some of the prevention work of getting the right visual supports. They were modifying rooms. They were doing all sorts of things. But this part looked really at the kind of the medical intervention of this work, and what were the docs going to do, and the nurses, and how would they intervene. And they created a group that got together with psychiatry and created a PRN algorithm of how they want to do it and when they introduced this, et cetera. And what happened is they were able to actually really reduce the use of restraints as well as the use of intramuscular medications for agitation, which was two big success stories, right? Because we don't want to restrain patients, and we don't want to have to get to IM medication level. And so they had really good success in getting those really nicely down, in addition to doing environmental modifications, et cetera. So the encouragement is to really, it's really important to look at all of the systems across the hospital or in an area to really kind of modify and adjust those. And it takes a village to do that, to kind of get those interventions going. So we've ended up in our emergency room with a subset of rooms that anybody with behavioral health risk is more likely to get to. Now, if you need trauma, you're going to go to the big rooms that have all the stuff in them for sure. But then we have a lot more proactive management of agitation. We have a lot more information. Our staff have protective equipment. We have schedules and tools and timers and things down there that they can proactively do. We have some engagement activities they can bring in to try to keep kids busy. They know who they can feed and who they can't feed to kind of, get snacks going and keep them just more sedate. They have activities to do. And then they have a higher level resource, which is our behavior safety team, to call if their base level isn't working, right? So they have a base set of things that they do in the emergency room. And if it's not working, they can call us and we'll try to bring it down the next level of intervention. So it's just been building layers of system. But when what we found when we worked on some of the environmental pieces, we didn't have the docs and nurses on board with the agitation management piece. So we had a disconnect, and then we were getting to restraint and needing higher level medications because of that disconnect. And when they were able to parcel that out more specifically and have that team work on it, we got a better connect. So we didn't need as much restraint. We didn't need to go to those higher level medications on patients. So just one example. Another thing that's been really helpful, and I think I didn't do this chart, but I've done about 1,000 of these across environments, is just doing basic, this is a Pareto chart of types of injury. And that's really helpful to know how, not only if your staff are being injured, but how. What are the types of injuries? This helps us feed right into what kind of protective equipment do we need for our staff. And then we're still looking at maybe what are the situations that cause those injuries, but this is just one to look straight at how are our staff most likely to be injured. And in the emergency room, we might break down the struck with were they actually hit or was something thrown at them, right? So we can look at that environment more specifically. But it's really important to kind of think about these types of things so we're getting the right equipment to the right rooms appropriately. I've done these charts for our PACU, so our recovery unit from our same-day surgery. And we found that a lot of them had like stethoscopes around their neck or lanyards on or things. Our hospital's now done away with all lanyards. It used to be you had to do breakaway, but now they're like nothing's around your neck, period. Just because too many get pulled and then it causes neck injuries, those types of things. But this feeds so much because that was the way we got rid of lanyards. That's the way we started telling every resident and the nurse in orientation, do not put the stethoscope around your neck. You may put it in a pocket. Do not put it around your neck. And those kind of got built into our culture and our system. So it's really important to know what kind of injuries are occurring and how people are getting hurt so that you can start educating them. And then we also use that to equip it with protective equipment. So even if you don't do a whole QI project on this, just using some of these tools is super helpful. The family, the best person in the world when a child comes into the hospital is their parent or caregiver. Your approach is important to that. Making sure that they know that they're part of the team, that they are the expert in their child, and that you want to hear them will bring out a whole extra set of information rather than if they don't hear that message from the front. What I know is that many parents of autistic children feel like they are not listened to across lots of environments. And so when they walk into the emergency room or the hospital, that may be the history they carry with them. And that may be how they respond to the doctors and nurses initially, because that's how they're used to being treated. They have to defend their child from the get-go. And so it's really important that that first introduction with the family, that we stop and introduce and set them out as like, I understand your child has autism and I want to learn about them and help this go as good as we can make it go. And that will often just go, the what? You want to do what? And it will help them. So our team often goes in at admission if the nurses do a screener, and if they're screened positive for behavior, it's an automatic page to our team and we'll go in. So pretty quickly in the admission typically, but we can also be referred in the middle of admission. And we, we'll explain our process, and we're here to help your child have the most successful, admission they can have. But oftentimes you just see the relief on a family. Other times they still, will say my family doesn't have any, or my child doesn't have any problems while they're pulling their hair. But again, that's a family who's usually struggled with the stigma around the child's behavior, and we work through that. But it really is important to understand, again, that baseline, because that change from baseline is how we determine often how they're doing, especially if they're nonverbal. There is a study out, and I can't remember who did it. It was more recent, but really looked at adults with disability, especially those with low verbal, and experiencing earlier death because of that communication gap. And so it's so important that our medical teams learn to understand this baseline, how they communicate, and look at health through that family's eyes and through these things, because it really makes a huge difference in their healthcare overall. Pain tolerance for individuals with autism. I'm going to talk about this a little more specifically in a little bit, but again, it can be very different. We often, very often see a high tolerance for pain, but that doesn't mean that they never experience pain. What that means is their threshold is moved. They under respond, and then they almost over respond. By the time they hit it, we're like behind it, and we're in a mess. So then we're trying to play catch up, and we know that that's always hard with pain. It's important to know what the triggers are going to be at the hospital. So what are the common triggers, and what do they expect will be challenging for them? We just need to know flat out so that we can start to work on it. What kind of behaviors we think that they're going to exhibit at the hospital, what works, what helps keep them calm, what ideas can the family give us that might help. Sometimes if the family says, I don't know, which they often do, I might say, well, what helps them at school? Well, they use schedules and this and this. I'm like, okay, we can do some of those interventions too. So even if the family doesn't use those at home, I might ask what works in another area or in another system. And then any ideas for preparing for care. So many families can say, oh, they do really good when you use social stories, or you show them, or you do these certain things. Or if you show them, they're going to actually be stressed until the minute of the procedure. And both of those answers can be correct, and we need to manage those differently. Okay. This is me as a sample of a PDF, or it's actually a Word document that families can actually use to fill out information and bring it into you. And this one is comprehensive, so it has schools and daycares and things that you may not need in the medical environment. And I'm not suggesting they have to do this one. There are, I listed a whole bunch of others that are called like health passports. And then you can do a grow your own. But it is helpful for families to sometimes just have something that they fill out for the team that they create, and they just fill it out while they're waiting. Or while they're working, and it helps the team have then a written thing. That I would still have a conversation, because you'll want to ask questions, but it is really important to think about, how do you gather this information in a systematic way and then pass it along your team, right? So those are some ideas for, and what I found is teams like to get different things based on who's there. Think about your electronic medical record, right? So we're all in these EMRs. They're all different. We use Epic, and we have developed several tools in Epic to help us with communication. And so one is this patient chart advisory. So our behavioral safety team will actually gather the information from the family. And the nurses have some too. We actually have some doc flows in our doc flow rows that we share with nursing. So nursing might grab it and it pops into ours. We might grab it and it pops into the nursing, so that we're sharing rows of information to help ease our assessments. But anyway, we will gather information, and then we will put in this patient chart advisory. And when you open up Epic and this child's record, it is on the right-hand side of the record, no matter whether you open an ambulatory, whether you open it in inpatient, no matter where you are, and it pops up, and basically it's a thing to say, hey, this child we just call it potential security risk because that's the name of the flag, but they have a risk. And then we have developed a standardized way to communicate that risk. So and it's basically like a teeny tiny mini behavior plan. And it's super high level. So here's how they communicate, here's the individual with key diagnosis, here's how they communicate, here's the known triggers, here's some basic strategies. We put in our behavioral PPE, so what should staff wear? Consultation is basically what support do they need in ambulatory, and then we give them a risk level, which is standardized. So, and that's developed over 10 years. But we used to just have a little paragraph that somebody typed up and wrote, and we have a limited number of people who can actually put these in. But I've seen systems who have nurses are trained to kind of gather some kind of a systematic set of information and just plop that information in. And we try to write it in a way that will not promote stigma. We really just want to say, this is how to help this child. This is how you help them navigate this environment. This is how you understand the risk of their behavior. So, because most nurses have told us, we just want to know if they're going to bite us or hit us, but that just helps them think about when they walk in, right? So we put that information right in there. The form on the left is actually something that we developed that it actually auto-populates from information in our assessment that we gather in our doc flow row, but it actually just gives this usually it's a 1-page, sometimes it pops onto the back, and it's printable, and it actually attaches to the longitudinal plan of care in Epic. We attach it to a thing called My Story, but it attaches several places so that people can find it quickly, and it's also in our notes. So it is just a quick, and again, it's a little bit bigger than this patient chart advisory, but it's a really basic behavior plan that goes wherever that child goes, and it can be easily pulled. With the CARES Act too, the parents can actually get this right off of my chart as well. So these are some ways that we've tried to take information that we're gathering, put it in our electronic medical record, pin it in places in Epic so that the different teams can learn how to find it and use it very quickly to provide quality care wherever this patient may go in a quick way, with trying to reduce the number of clicks we have in Epic, which is what everybody talks about when we're trying to get things efficiently. And again, these didn't get developed year one. They have been slow developments over time, but it's really important if you want to think about having building this as a systematic level across your teams where they start to learn how to do it. And when things are presented in the same way, then they learn to know to go where the information they need is. Okay. So breaking down a little bit by area, emergency rooms, thinking about those the best rooms we talked about, developing a toolkit, which is something we'll do a little bit later. How to expedite patients to rooms. So we have a process across our hospital, whether you're in ambulatory, our same-day surgery, you're getting admitted to the hospital, or you're in the emergency room, to try to identify patients who are going to do best when they're pulled out of those waiting rooms quickly. And most of our patients with autism are in that category. Not everybody. And sometimes it might be in some areas they're asking, how did they do in the waiting room? Other times it's just observing that the child's already melting down, but trying to find ways where we can expedite and get them out of the waiting rooms, because we're preventing a crisis. We see this risk, and we've tried to put it across our system. When we're doing planning, so we plan for patients who are coming. Our highest risk patients get planned for when they come into ambulatory, or they're going to do a planned admission. We have a team that those flight, or the flag that I showed you on the patient chart, that potential security risk flag, that actually can be pulled up in a report, and we kind of know where these patients are going so that we can provide proper supports across, or alert teams that they have patients coming in who need extra support. And this allows us to bypass admitting, and we'll do admitting in the room. We just take them straight up, get them in the room, and our admitting comes to them. So that didn't used to be a possibility at our hospital, but now we have adapted all this care to try to not have individuals melting down in our admitting areas and melting down all over our hospital, because all these crises can be prevented with a little bit of pre-work. And it took us a while to get there. So this isn't easy, but you really can do it and have it not disrupt the flow. It is so much more disruptive to the flow to have a child that you're trying to get off the floor in the middle of a hallway up to a room, and then they need all this support to get there versus just have the family check in, go up, and bring admitting to them. So we have learned, again, I think we initially were told that this is hard, this isn't our system. And what they learned over time is like, it's so much faster to take them up. It's so much faster not to have this crisis. So it really does work in your effort. The effort over time works to your advantage, even though it feels like a lot in the beginning to make those changes. Again, having those schedules and visuals and supports that you can pull out anytime needed. And truly every different place, I've been at Cincinnati Children's for 21 years, and every place that I've gone to has a systematic set of visuals when I leave because we just have to have these things that are available all the time quickly if we're going to prevent crisis from occurring. So thinking about all the places that these types of tools are needed, and developing toolkits is and then how do you sustain the toolkit is very important. And then again, that family time. So, we struggle as providers to try to get families through quickly. But I think I've been known to tell some of our leaders that we're not a factory. And so while we need to move efficiently with flow, we don't want to be so efficient we feel like a factory. So we've been able to build the processes to get information in to help reduce the amount of time that providers have to spend re-getting information from the family each time it's new, because if they can pull that behavior plan and they got a base, they can just clarify with family and move on more quickly. So our time up front, again, is really useful. But if you are a provider who is seeing this patient for the first time and have not been in our hospital, and we weren't aware of them, then you even have an idea of the types of questions we ask because you're used to seeing that information come through. And then it just starts to develop a seamless. And then you refer to us. You might get it for your own use. You refer the patient, and then we get them in the system. So again, just developing that higher level systems work to get patients and families, the information going through. And I think our emergency room is the hardest one. So even though we have all these tools in our EMR, depending on how fast they need to go, it can be hard for them to pull the information. And we are still working on the improvement of that work. And again, challenges are the things that help move the work forward. It's a kind of unfortunate sometimes, but I think they are starting to identify when you have a patient and who's checking to see if there's a risk flag. Now all the whiteboards show if they have that little potential security risk flag, so they can look up quickly and go, oop, that patient has something I need to check. And they'll get somebody on that team will pull that information, get it out to the team. So they are developing the systems to, again, leverage that technology to say, if I can get a visual indicator that this patient has a risk that I need to be aware of, this admission is going to go a lot faster if I'm aware of that risk and have all these strategies at my ready. Okay. And then just trying to avoid traffic in and out of the room. Again, the emergency room can be really hard for this. And at the same time, not help the family feel deserted, because we sometimes go so far to keep people out of the room that the family feels like nobody's around. And so that's not good either. So trying to find that balance and making sure that they still need checked on, that somebody should still be feeding them in with what's going on, but just being aware that just the constant pop in may be pretty disruptive as well. And then whatever we have to do an intervention, it's like we want to order this. How do you think that will go? And the parent might be, well, what does it? How do you do that? Okay, this is how we do it. Okay, and then talking how they'll go, and then making a plan. So we're really good at saying, hey, I want to get some blood work. And that's great, but the parent may not know if that means I get an IV and you're keeping an IV in because you might want more, or if you're just doing one blood draw. So it's really important to explain to them what's normal to us. Oh, I'm frozen. There we go. Okay, inpatient. If it's a planned admission and a social story can be provided prior to arrival, this is super, super helpful to just have the patient know what's going to happen when they get there. That preparation can be really, really helpful. Best rooms, knowing every unit, knowing which rooms are the best and kind of what an individual might need. The sensory is all the same. The visual schedules and the toolkits are all the same. Routines are super, super important. They're harder to do in the emergency room with those shorter stays. But in an inpatient hospitalization, these routines are huge. So if the patient is very sick, they might sleep whenever because they just need to, and that can be okay. But as they're getting well, or if they're not in for an ill visit, but more in for a clean out with constipation, etc., it's really important to even just work with the family. So, what is their normal routine, and how can we establish as close to that as possible throughout this day? So, even helping parents know that the child can eat normally. So go ahead and get your or order your meals on your regular schedule because you have no food restrictions, right? So just helping the family think through that because they're completely out of their routine too. And so helping them think about just make sure we do this. What happens a lot of times is we're not ordering food till it's time to eat, and it takes 45 minutes to an hour to get it to the room. And then the child's starving and they're hangry, and now we've got behaviors. So it's really helpful. Parents don't know how long it takes to get these things done. So we as hospital employees have to kind of fill them in on. So it'll take about an hour for your food to get here. So making sure you're ordering it in advance, so that we don't. You can order some extra snacks up that you keep up here. We have a kitchenette here with these kinds of snacks. You're welcome to go get those as needed. Just laying the all the things down that they might, or what are you worried about, in navigating kind of a thing. Same thing if they can leave the room. Here's our child life room schedules. I'll send in the child life specialist, and you can arrange like when you can go or how you can go. If the child needs a lot of activity, we can think about how can we get them out to move and walk, etc. And that will depend on infection control policies, etc. We have a whole process we go through if we have a child who needs to be in isolation, but they need movement. So we have some special things we can do to actually get them out of the room at specific times with specific precautions. And we worked this all the way through, and we only do it if we need it for behavior management, because otherwise it's safer to keep them in their rooms. But sometimes we have, kids become a fish in a fishbowl, and it's just not pretty. And so again, we have to step back and think of the big picture. We can't just be limited by policy after policy, but we also can't put everybody at risk. So it is this huge balance of discussions in terms of what you need. COVID threw us, into all sorts of loops. But again, over the course of a year, we learned to navigate those different loops. Can the child come out? Will they wear a mask? Will they not wear a mask? Can we practice a mask? Can we, blah, 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 and doing all these things, but trying to again, adapt to environments. And it was certainly harder before. It's gotten better. But still, we're going to continue to run into roadblocks in the world like this. And once you have a system that is used to adapting, you just tackle that next thing, get people together in a room and problem solve and move it forward. Okay. We have found that when we help families rest, it's huge. So getting them to go home to sleep at night, if the child sleeps pretty well, or if they want to stay, that's fine. But maybe sometimes we just add a staff at night just to help the family sleep. We have other families who don't like a staff in the room while they sleep, and we understand that. But if they're not getting any rest, we're going to sit and have a lot of problem solving conversation around how do we get them to rest, because a rested parent is just so much better to navigate the world with. And then we do a lot of one-to-one staffing, and sometimes the parents want it with us, and sometimes they don't. And we try to, we work with them to convince them. If we're having a lot of injuries, sometimes we require it. But it's all a discussion with each and every one. If parents can manage their children, we don't want to add the resource, and that's fine. But if they need help, we're not going to judge them for needing help. This is a hard environment. There's a lot of lines. There's a lot of stress. And sometimes with the help, they just manage better emotionally, and the whole admission goes better. So again, just trying to make sure that we're supporting that. Our staffing are also specialty trained in working with this population. I'm not going to go too much on clinic appointments because we're focused mostly on hospital. But again, this is the great time for pre-planning. Clinic appointments are known in advance. Typically, you can do walk-ins, but they're rare. But again, expediting if needed. Not every child with autism will need an expedited room back, but knowing if that's a problem is super helpful. Developing a social story just for your clinic, and you can give it out to whoever needs. Once it's developed, it works. You don't have to adapt it to every single child. Um, Although sometimes there's a special thing to do. Again, having a visual schedule that goes along with your clinic is super helpful. Um, and then thinking about that space and how you set up your environment. Again, oftentimes there's a variety of clinical rooms, and if you need a specific space for a specific individual, how do you manage that? And how do you manage all that overload? We do have some parents come in and look at environments before they bring the child, and they just do better. If the parent can predict it, then they can predict it for the child all the way better. So we'll bring our child life staff does this a lot, but they'll bring in families and show them spaces prior to an appointment, even if the individual, even if the patient themselves doesn't come in. Okay. Oh, and this last one, tweaking the environment after each visit is huge. So tweaking your strategies and environment, how did that go? What could we do better? So we do continuous improvement with this kind of work. Checking my time here. All right. Adapting care, much of this is repetitive again, but everybody having an expert is super helpful. Especially for maybe providing some initial training, and then you have some folks who continue that going, but also just consultations, right? So you will run into roadblocks with specific patients that are super hard. We still run into roadblocks with specific patients that are super hard. So I don't see every patient we serve by any means, but there's a subset that I see their entire admission because they're very, very, very challenging. And so it's really important to try to kind of build those resources, even if they're not within your inpatient, that you find somebody in your region or your state that will be able to consult with this. And the ECHO autism models are perfect for this, and can provide you a lot of resources that you may not otherwise have in your hospital, but the ability to do case in that community. You basically have a community of experts who wants to help every autistic patient ever. So that you can always find somebody within that community that is willing to problem solve. And again, that constant communication with parents in your weights. For rounds, we have a lot of hospitals that are teaching hospitals, so they bring multiple people in to do assessments, and family-centered rounds are often done right at bedside. And again, with this population, you have to think about, is that the right way to go? And so, do you have to bring the attending, the resident, the senior resident and the medical student all in for the assessment for this patient? And can you reduce that down? So it might work for some kids, and that's great, but really talking to the family about how much they can tolerate, and making sure that you try to balance your teaching as well as overwhelming the patient. Same thing for rounds. We often are pulling parents outside of the room for rounds, but also know that that needs the family may need a little bit of a time to plan to get out of the room, because sometimes the parent leaving is also a trigger, as well as everyone coming in. So you really have to think about rounds to make sure the parents can join and it can be effective. And typically, if there's just enough time, it gives the time for the nursing team or the staff in the room, et cetera, to get the child doing something pleasant and engaged, and even scheduled to say, mom's going to go to a quick meeting, she'll be right back, and they see that on the schedule and you've prepped them and told them, and then they can just do fine. And especially, again, if we keep that routine over days and they know that sometime in the morning, mom's going to be pulled out and then she's going to come back, they'll get that routine down and they do really well. So it might be hard for a couple of days and it tends to improve. So we don't have as much trouble with this at all anymore. But I would say it used to be something that was harder, but now our teams just know to prep that patient. So the teams will often say, hey, we're on 2 patients before, and the bedside nurse will go prep, and kind of everybody gets ready to roll. And then we have a kind of a seamless ability to get them in and out. So again, a lot of this is just pre-planning and prep, which can be built into your system for sure. And then sometimes we need to consolidate care, and sometimes we need to spread care out. And so again, the spectrum is the spectrum. Not everybody is the same, but really thinking about, is it better once you're in there to do a lot of things and just get them done so they can have longer periods between care? Or is this the child that is going to do a lot better with just a little bit, and then come back and do a little bit and come back and do a little bit? And again, the family can kind of give you ideas on that. Or they may not know, and you may try it one way and then decide it's not working very well and you need to try it a different way. And don't be afraid to kind of work on the changing those strategies, but just know like it's working with finding what works for that individual. Okay. And then I always try to set up something fun after, the hard things we do. Somewhere along the way, our GI team decided that rectal irrigations were good for everybody who has constipation, right? So it was a change in the standard of care. So when we first started, they'd do clean outs, but they hardly ever did a rectal irrigation. And over time, it became a standard of care, which really made me stay up at night for a while when they really changed the standard of care, because who wants to have a rectal irrigation? But it's amazing because with some planning and some work, we have made this a standard of care. It helps the clean outs go quicker, and the kids actually tolerate it pretty darn well because we've done a lot of work around it, right? Work prepping the parent, work on how we approach it, work on all the different aspects of it. And then if it isn't going well, we have a whole bunch of ways we can adapt or change or modify or work with that team to make it different. And so some kids don't get rectal irrigations, some get them less often. Some get, it just depends on the tolerance and how we can adapt. But again, that adaptability, 10 years ago would have been a nightmare. Now it just becomes this thing where we go, okay, here's a new thing. And we put our heads together and get a lot of, input and then, have a subset of things we can do with every family that just kind of fits the family and the patient. And so it becomes something I hardly ever hear about anymore. We just have it on the board. They're getting rectal irrigations, Q2, Q4, Q6, whatever it is. Pain versus agitation is probably one of the most important things we've worked on in the hospital, emergency room, as well as inpatient. You have to know the baseline, and you have to listen to the family saying that this isn't normal and the triggers aren't normal. And you have to know the pain tolerance. So those things, putting those all together makes it work. A lot of our pain rating scales do not work with individuals on the spectrum. We miss those early signs if they are a high pain tolerance, and then they get frustrated really quickly. When individuals with autism have kind of chronic pain issues or are dealing with something painful, what happens is their triggers are typically still there, but their fuse is so much shorter. So they might still be having responses to normal behavioral triggers that they do, but it's either a much bigger explosion or a much faster explosion when they're upset. And so the family is still just, you can be like, well, they just got mad when you took the iPad away. And the family can say, yeah, they usually get a little frustrated when I take the iPad away. They don't usually tantrum for an hour. This is out of normal for them. So the thing we initially saw the most with is physicians saying, well, they're mad because you took this away or they didn't like something. And it is true, but the parent missing the point that the parent says, but it's so much different than it is typically. So yes, that's a trigger, but it is way bigger now. And sometimes it's like, well, that's just because they're in the hospital. And so there can be a lot of things said that feels to the family like poo-pooing that behavior or that trigger, when they really in their heart of hearts know that something's wrong with their child. So, and sometimes the child has had a grand workup, and it's an amazing workup, and the team has just gone to the ends of the earth to figure out what's uncomfortable, and they can't figure it out. They can't find anything massively treatable. And the question I usually pose at that time is to say, if this child had the language to tell you, but my stomach still hurts, what would you do? Even if you'd ran the same workup, but they could still say, but it still hurts, then what would you do? And often what happens is they get referred to pain team, or they get referred to another resource to look at more chronic pain, or, maybe it's irritable bowel, which is harder to diagnose a reason for, or whatever, but they would do something else. And what happens often with especially nonverbal or low verbal people who have autism or other developmental disabilities is the assessment's more likely to stop, or the intervention's more likely to stop because they can't specifically communicate. And that's been the hard advocacy work that I think we are finally, like, I feel like have a pretty good handle on. Now this conversation goes so much better than it used to, but it is really important to, again, hear that family and understand, even from a medical perspective, that we often have people with pain that we don't know why they have pain. And so that doesn't mean they don't have pain. So really listening to this family when they know that this is discomfort, and and kind of working with that. That doesn't necessarily mean they have to stay in the hospital forever, but it means that they need to go on to the next resource that's going to work on the fact that we've done this huge workup. We can't find anything specific to treat, but this child is still expressing behaviors that demonstrate discomfort. And so what's our next level? And treating that is super important. Um, and we have found significant things that they can treat, based on these things, which have taken crucial conversations. And these are over years, but we had one young man who'd had a perforated bowel, had a big resection, um, and he was super docile in the hospital, but I knew him really well. And I would never use the word docile to describe this young man. In fact, if he wasn't up, moving, shaking, and trying to bite me, something's wrong. Because that was, he was uh, quite a busy guy, and typically the biting was because he was into things he shouldn't be in, because he was always into everything, and he struggled with engagement. So in a room, he should have been pretty bored and wanting to be all over the place. And he wouldn't. He would lay there, and he started to get up after his surgery and do some things and do better. And then he started laying down again, and he didn't want to get out of bed. And I was like, something's wrong. And they were like, he's doing great. And I'm like, he's not doing great. This is not great at all. And it took me a couple days and some, I think initially I got them to increase his vital monitoring. His mother was not at bedside. And there's probably no worse situation than a child who's nonverbal who doesn't have a parent constantly at bedside. It's one of our biggest challenging situations. And they had reason. They had many other children at home, and they lived 3 hours away, and it was a really complicated situation. So she was calling regularly. She really cared, but she couldn't be there at bedside. But anyway, we worked with this team and increased some monitoring, and he did develop a low grade fever, and they were like, okay, we're gonna image him. And he had a big abscess in his belly and needed wound vacs and was pretty sick. And they, the surgical team had said, they were like, I would have had no idea that it was this severe. And I said to them that that's why you have to understand baseline. Like, you have to understand each kid's baseline, because he was super docile. You thought that was great. I understand that, but you made an assumption. And when it comes to autism, that's going to do in your clinical judgment every time, because you have to know the baseline and the change. And so lots of learning on that case, and he ended up doing okay. But and he got his abscess fixed and went home. But again, these can be critical. Had we not been there behaviorally to, to advocate for him or to push that, he may have ended up septic. So it is super important. Critical things can come out of this. So understanding that baseline is critical. Understanding the parent saying something is wrong, and understanding that doesn't mean you have to do more workup if you've been really thorough. But you do have to consider that individuals with autism are still prone to all the other pain syndromes that a typical population can have. Just because they can't communicate it doesn't mean they won't have it.